Good afternoon. My name is Corrine Jabes. I'm Department Head of Obstetrics and Gynecology and Team Lead of RPIW number 8, designing a high-efficiency surgical short-stay unit. This is our agenda, and this is our team. I'm privileged to work with such an enthusiastic and dedicated team with a variety of skill sets and experience. Collectively, we have 120 years of experience in healthcare. Our goal is to design a high-efficiency surgical short-stay unit at Pascal Hospital through the development of standard work. There is a provincial target to achieve a 3-month wait for surgery by March 2014. Improved flow of surgical patients will be achieved by the creation of 2 short-stay units with 8 beds at Pascal Hospital and 12 beds at Regina General, improving inpatient capacity for surgical patients. The short-stay unit at Pascal Hospital will be staffed with 1 RN and 1 LPN with 12-hour shifts. Support staff is yet to be determined. In order of volume, this will include orthopedics, general surgery, urology, as well as smaller volumes of other subspecialties. The Regina General Hospital site will also have a high volume of gynecology. Current demand is 1,100 patients per year. 10% are admitted through day surgery, requiring inpatient stay, often because of nausea or pain. The rest are equally split between planned elective inpatient surgery and emergency cases, both with anticipated lengths of stay of less than 48 hours. To achieve our target of a 3-month wait by March 2014 for short-stay elective surgery, an additional 3.4 patients per week would require surgery. With the 24-hour unit, current demand of 3 patients per day plus 1 additional patient on the weekdays, we calculate a TAC time of 360 minutes per patient. We anticipate turnover of approximately half of the patients in this unit per day.
Hello, my name is Mike Higgins. I'm sub-team lead, and I'm told token male on this team. So, our target progress report sheet is up on the screen, and in establishing our targets, we did want to focus our attention on freeing time up for patient care and nursing care by making supplies more accessible, reducing the amount of supplies to what is exactly needed on the ward, reducing walking distances for delivering care and for retrieving supplies by reducing paperwork and the time required for charting, and so on. Our value stream map, current state, basically we've focused on the time of arrival on the unit post-OR to time of discharge from the unit. So our patient, the unit is being designed to run for 48-hour patients, may go to 72 hours. So the lead time on our value stream is essentially based on 48 hours. We're focusing on adding value-added time for nursing and staff roles. Our future state map, as you can see the distinction, basically it's the same lead time for patients, same focus, but we've acted on many of the Kaizen burst opportunities for improvement, and we've rationalized roles for our staff.
My name is Chris Faco, and I'm a unit clerk on the day surgery unit at the Pascal Hospital. My goal for the RPIW 8 was to establish an efficient working space for the unit clerk and the nursing staff for the new surgical short-stay unit. My idea summary sheet shows a before and after of the unit clerk work area. This picture shows a pre-Kaizen of the unit clerk area with the pre-5S score of 1.2 and then a post-5S score of 2.8. I also developed a Kanban system for the unit as well. This is the nursing station before and after I 5S'd. There were items that were removed from the new units. Next one. I also developed a supply list that I felt would benefit the staff. A standard work form was developed for the surgical short-stay unit staff and for the unit clerk as well.
Hi, my name is Leslie, and I work as a service aide here at the Pasqua. I have been part of a working team working with a new system for linen and supplies called the Kanban system. Our intention was to also reduce necessary supplies in our patient rooms. Our new unit's patient cupboards are now empty.
Hi, my name is Brenda. I'm an LPN at 4C at Pasqua. I've been a part of the team working with supplies on a Kanban system. The supply room, the supply cart, and cupboards are now all in color-coding Kanban 2-bin system. Never run out of supplies, easy to find, easy to restock, and keeping track of what is needed or what can be added, therefore improving time and costs. We also developed a Kanban post, what supplies are needed on a daily basis, eliminating large carts and anybody checking for stock. All medication supplies are at arm reach, reducing time. Everything is in a 2-bin Kanban system, cupboards on top, a patient medication Pyxis. There are medications that can be dispensed on time, safely to the patient, and reducing nurses' steps. The nurse's supply cart. This is a cart that supplies what a nurse will require for patient care during a 12-hour shift. The cart is mobile, organized, labeled, and therefore decreasing steps to get supplies from the supply room. A patient's room kit, reducing supplies in a patient's room. Kitting is what a patient would need when they require for their short stay. They can be pre-made and ready for admissions. All standard forms were made for all of these areas and are all consistent with infection control.
My name is Sherry Blayon. I'm the clinical nurse educator for the day surgery units as well as for the upcoming short stay unit. Something that we discovered is that nurses do a heck of a lot of charting, so we're wanting to reduce the amount of charting that we do overall. So you can see our first nurse is drowning, and now we're happy with the reduced numbers that we are able to accomplish. So looking at a nurse admission, currently we have a 4-page document. We were able to actually create a 1-page, one-sided document to be used for the short stay unit and may go further. So we reduced the amount of time spent from 29 minutes to 15 minutes with a reduction of 48%. This is all of the nursing documentation that takes place while the patient is in hospital. We took a look at that and were able to eliminate many of them, creating a 1-page, double-sided document that would have all of your nursing documentation for a 12-hour shift. Looking at discharge, we were actually only able to add a piece, but this is currently being done with a lot of the D system. So we created a checklist to ensure that the patients are going to be good to go for discharge, including them in the conversation as well as physicians. We created standard work to ensure that the admissions and discharges are done in a standard way. And we also took a look at the physician's workload as well. There are many sheets that aren't done consistently by physicians, and could they be eliminated?
Hello, my name is Sherry, and I work in the day surgery unit here at the Pasqua Hospital. As a team, we've decided to implement a concept referred to as Purposeful Rounding. This concept deals with performing hourly checks on each patient to address concerns regularly. By anticipating 7 Ps, we can increase patient satisfaction and decrease the need to utilize call lights, therefore reducing repeat visits to the patient rooms. Purposeful rounding will also increase patient trust and provide consistency of care. Standard work has been created to ensure that this concept is performed consistently. The other concept that we will implement in this unit is a bedside handover system. Instead of traditionally handing over between nursing staff, either at the desk or in a closed room, we'll actually conduct the handover at the bedside. It eliminates the need for gathering information needed to give handover and allows the patient to be as informed and involved as the healthcare team members are, therefore making them a part of their own healthcare team. This approach will also give them the opportunity to ask questions and be informed about their plan of care. At this time, the oncoming nurse will update the whiteboard on the inside of the room, and we've created a standard of work around this concept. We have a multiple skill training checklist to ensure appropriate standard work concepts are reviewed and understood by each member of the healthcare team.
Hi, I'm Sheila Anderson, the director of the Surgical Kaizen Operation Team. An important part of our week was to incorporate the concept of visual management. This is to ensure that we have efficient patient flow and communication flow. So in addition to the visual management of 5S and Kanban, we also developed 2 whiteboards. The first whiteboard is for the patient, solely for the patient, and are essential to help them understand their care plan each day. So we want them to be, or many of you are familiar with boards. Unique to this board is an area where we are able to outline what the patient can expect in their care plan that day, on a particular day, their pain medication schedule, as well as discharge date, and more importantly, the time that they'll be discharged as well. We also incorporated a really patient-friendly portion of the board, which is where families and patients can ask questions to their healthcare providers and their physicians, and also an opportunity for them to comment on how we're doing with their care. The other board that we developed was a provider board, and it's located outside the patient rooms, and it has colors and magnets to signify the flow of patients and the flow of the care. This is used by all of the care team coming into the unit. And each one of these boards, we develop standard work related to it.
Hi, my name is Julie. I am a registered nurse and I do work at the General Hospital in the day surgery and day admission surgery departments. I'll be comparing distance traveled by our study nurse pre and post Kaizen by example of the spaghetti diagrams. So pre-Kaizen, our study nurse walked a distance of 1.8 kilometers in a 12-hour shift. Post-Kaizen, our study nurse walked a distance of 1.55 kilometers in her 12-hour shift. So this works out to be a reduction of 14% per 12-hour shift. With the use of the new documents, which were separated from the patient chart onto a clipboard, the nursing team reported a decreased need to go into the patient chart and less time was spent flipping pages to find the correct spot for charting. The documenting was straightforward. Nursing had access to their documents during doctor rounds, patient therapies, and diagnostics, and reported once they were familiar with the new documentation and flow sheet, the sheets themselves became easier to use. With the concept of the purposeful rounding, the nursing team was able to provide more time individually with each patient, and doing rounds together provided assistance if needed and open communication and assessment for the nursing team.
My name is Donna Strudwick, and I'm the patient participant on Team SS. Historically, as a patient, when I come out of surgery, I'm thinking about two things. Number one is the fact that I'm feeling very ill and I'm hurting. And number two is I really want to go home. With that in mind, we've created a bit of a process, and all through visual aids, which will put the patient and their family into the driver's seat as they travel down that journey towards discharge. Firstly, the work standard for pain management includes a pain chart, which the staff at 4C have freely shared with us for our use. And it simply describes the levels of pain using a 1 to 10 scale and goes on to describe the various means of pain management that are available to the patient. That puts me as the patient being able to assess my level of pain and knowing how I want to manage that pain. Secondly is my favorite. It's called My Ticket Home, and it is based on a simple stop sign format. I know that if I achieve everything in that green area, I'm going to be able to go home, but if there are some things that still show up in the red area, well, I might be staying for one more sleep. These two visual aids are very patient-friendly, and what they do is they eliminate, in a lot of cases, the need for a patient to use their call button. These two things, combined with the discharge worksheet that you saw in Sherry's presentation, all combine to make the discharge more efficient and very streamlined. Thank you.
So what you're looking at on the screen now is an example of a, of a multi-page time observation form that has been filled out by our team. Many of these time observation sheets were completed pre-Kaizen and post-Kaizen, and just a note of appreciation to all the staff who tolerated us following them around with our stopwatches. The information we glean from these, though, is invaluable. We use it to establish our standard work combination sheets, And the pre-Kaizen standard work combination sheet does show a pretty clear picture of a disjointed workflow with a lot of back and forth being done by the staff. The post-Kaizen sheet shows some improvement, particularly in the level of regularity of the movement. The information is also used to develop our percent load charts. The pre-Kaizen percent load chart in front of you there shows basically the distribution between direct care and indirect care, the yellow shaded area being the direct care component. The post-Kaizen percent load chart does show an improvement in the degree of direct care through reduced charting, of which was reduced by a full 10%, and also through the movement of the staff. We anticipate that there will be continuing improvements as the staff get brought in and start to work with these new processes. Finally, I'm just going to comment briefly on our newspaper, which is the to-do list that we'll be handing off to our process owners. There are more than the usual number of to-dos on this list, but that is reflective of the fact that the unit we're working towards is not operational yet. So there are lots of things for them to do. Most important of which is to develop the standard work and ensure that all employees are trained to the standard work. There are a number of things that need to be done, ensuring that missing supplies that were identified are fully stocked on the ward so that they have what they need when they need it. We need a Pyxis medication fridge to be installed. We need to order the new forms that were created, and so on. So there are a number of to-dos to follow up, and with that I'm going to hand it off to our team lead.
So here's our final target progress report related to supplies. Our square footage occupied by supplies per patient was reduced by 78%. The number of items in an inpatient room cupboard was reduced from 152 items to 9 using the new patient kit. We were going to 5S the patient room cupboard, but instead we simply eliminated the need for any stock in the patient room. The pages in the surgical admission bundle was reduced by 35%. This is over 20,000 pieces of paper within the next year. Improvements related to changes in nursing care from documentation and purposeful rounding produced reductions in walking distance per shift of 14%, reduction in patient visits to patient rooms of 19% per shift, and increase in time spent in direct patient care of 18%. We are hopeful that the changes made, including anticipating the needs of patients with purposeful rounding and improvements in discharge planning, will prevent unnecessary delay in discharge and reduced post-surgical lead times. Our quality measures include a number of patient delays leaving the recovery room due to unavailable post-operative surgical beds. The baseline is currently 10 cases per month, and this will be recalculated following opening of the new unit. We had insufficient time to develop new standard work that would affect the setup time for housekeeping for patient room turnover, but we did discuss with infection control the need for cleaning of the rooms in such short lengths of stay. It was established that daily garbage removal and cleaning of high-touch areas, such as doors and bathrooms, is definitely required, but full room cleaning and linen changes is not required if there's a length of stay of less than 2 days, unless obvious soiling occurs. We did not have a productivity gain, as the baseline was 2 nurses caring for 9 or 10 patients, whereas the new unit has 2 nurses caring for 8 patients. Because of the small size of the unit and its physical isolation, further reduction in staffing is not an option. If the launch of the new unit is successful, there is potential to increase volumes by including postoperative lengths of stays of up to 72 hours, using the space preoperatively and postoperatively for day of admission surgeries, or actually increasing beds in that unit. For our workshop summary, we found that this was an opportunity as the unit was new and open, and the RPIW process was successful. We were able to reduce inventory, reduce time for the nurse, and paper. The lessons learned is that when there's positive change, it's met with enthusiasm, and the 4D nurses were very excited to see the new documentation. We also found that content experts were crucial for success, And barriers to change are not as solid as you think they might be. Ask the 5 whys and keep asking until you find out if the barriers are real or not. We have many thank yous, including our sponsor and process owners, our consultants and assistants, and many content experts. And finally, of course, we want to thank our patient, Donna Strudwick. Her views were absolutely essential to our work. Thank you.